And I would like to acknowledge that we are all meeting on unceded Aboriginal land. I'd like to acknowledge Bidjigal country, where UNSW is located, and also Darawal, Wadi Wadi and Yuin country, where I am today. And I pay my deepest respects to elders past, present and emerging, and of course offer a warm hello to Aboriginal people here in the meeting. We are joined today by the enigmatic, the ever enthusiastic Terry Slevin, the captain of the Public Health Association's ship, and we are very grateful to Terry for coming along to this meeting today, which is a mix of School of Population Health staff and members of the Public Health Association from across New South Wales. Thanks everyone for coming. We are very pleased that Terry has come along today to talk to us about the PHAA's election platform. Not long now till this next election, so a lot to discuss. I'm also joined by Rebecca Ivers. Professor Ivers will say a few words in a moment, and I think Kate McBride, Associate Professor Kate McBride, the President of the New South Wales branch of the PHA, is also, maybe if she's here yet, is going to say a few words. I will first hand over to Rebecca, and let's get the ball rolling.
Thanks so much, Rachel. It's fantastic to be here, and thank you so much, Terry, for joining us. I'm really looking forward to hearing your words at this time as elections coming up. Keeping public health in the forefront of everyone's minds, really important. As our great colleague Emily Banks once said, public health is the answer to just about everything, which is something that I firmly subscribe to. So Rachel has set up, and this is one of our great initiatives in the School of Population Health. Rachel is the inaugural director of the UNSW Public Health Advocacy Lab, which is something that we've set up to really make sure that our postgraduate and undergraduate students, and in fact all students, actually get engaged in public health advocacy. Public health really is a discipline that's all about activism and about advocacy. So the lab is a way that we bring students in, get them involved in campaigns and actually learn how to actually do public health activism. And this event is one of the activities of our lab. So really exciting to be here. Welcome. Great to see so many people from Public Health Association, and really looking forward to hearing what you've got to say, Terry.
Thanks, Rebecca. And I think Kate maybe hasn't quite
I've just got here.
Oh, fantastic.
Sorry,
Kate,
Rachel,
hello.
I was teaching.
That's okay.
Hello.
Let me introduce you. Thanks for coming. This is Kate, Associate Professor Kate McBride, everyone. She's the president of the New South Wales branch of the Public Health Association, and she's also an epidemiologist based at Western Sydney University. So I've asked Kate to just say a few words about what's happening on the state level before we hand over to Terry.
Thanks, Rachel, and thanks so much for hosting this event. It's fantastic to see University of New South Wales doing some work around the advocacy space, which, you know, we're really interested in New South Wales. And yes, this is about the federal election today, but certainly from a state basis, we're very involved in advocacy. And in fact, I can't really talk about it yet because I've not had a chance to read the report, but there's some promising findings that have come out from the recent Special Commission inquiry into healthcare spending that we put a submission in around an emphasis on spending on preventative health and potentially an agency that will oversee that in New South Wales. So that's really one of our big focuses in terms of advocacy, and then other work around gambling and obesity as well. But just to say, if there are students joining us today, we do have an executive committee, but we also have a newly formed student committee. So if anybody's interested in getting involved in public health and getting involved in advocacy efforts, whether it's writing submissions or helping to do research to do advocacy, then you're very welcome to join that student subcommittee and just look out for the call for nominations, which will generally happen around August or September each year. And I'll finish there.
Awesome. Thanks, Kate. All right, everyone. So how this is going to run, you all know the chat will be active, I hope. There's a lot of you on the call. We'd love to hear your perspectives and responses to the things Terry's going to share with us. If you have a specific question for Terry, it would be great, or for the panel, or for each other, put it in the Q&A, please. I'll be managing that and calling people forward to ask their questions when we come to the last section of the webinar. But Terry, if you'd like to share your slides, I'll pass the mic over to you. Thank you again.
Good on you. Thanks, Rachel. Enigmatic. I'm going to have to look that up and find out whether that's an insult or not. Thank you kindly for that very kind introduction. I thought it was funny. And let me see if I can just share that, make sure we can maximise that and see if that's what you need to see. Is that all going good?
Looks great.
Okay, lovely. Thank you. Again, thanks to the folks at UNSW. I had a quick chat with Rachel before we started to say what was the origins of this, and it started with a meeting with the public health team at UNSW coming back from the break, wondering about the world, Trump, CDC, and many other things. And that's how these conversations start, those kind of chats amongst public health people who want to try and find out what's going on. And that's the origins of the conversation. But before I go any further, I want to acknowledge the traditional owners of the land where I'm speaking to you from today, Ngunnawal and Ngambri country, and I want to pay my respects to the traditional owners of the land where we work and live, and pay respects to elders past, present and emerging, and pay respects to all Aboriginal and Torres Strait Islander people from all lands who may be joining from anywhere around the country today, and acknowledging that this is always unceded Aboriginal land. There's a lot to talk about, and I'm going to gallop through, and I have asked Rachel to throw a rock at me 3 minutes before 12:40, so that we do get time for Q&A, and I'm very keen to engage with you along the way. There is lots going on. The centre around which this talk is built is our election platform for the federal election. We know it's going to be called sometime between, my calculation is the 28th of March, and it needs to be called by no later than, I believe, the 13th or 14th of April, with the last possible date being the 14th of May. But we've been ready for the election in case it was called in December. And so these election priorities were signed off by our board, and they were signed off back in November of last year, maybe even a little bit earlier. And there's 7 of them, and we had a debate as to whether 7 was too many. And generally we like to keep this to 5. We like to keep it to chewable chunks, but there was a case for even more than the 7 that we've got. And I'm happy to take questions as to why there are various things that are not in there. But I'll tell you up front, the simple answer is to get cut through, we have to be as clear, succinct and targeted as we can be with our election asks. And despite public health covering many issues, there are things on sexual health, there are things on injury prevention, there are issues in relation to, for example, immunisation, tobacco and vaping, alcohol, many others that we could legitimately fit into this list. But we've landed on this 7 through a consultation process, giving our membership an opportunity to have some input. I'm going to bounce through these 7 priorities, and then I'll throw a little bit in at the end in relation to our policy process that gives you a sense as to how we land at the priorities that the PHAA focuses upon. And I'll open by simply saying we're a fairly modest-sized organisation. We have roughly 15 staff, some part-time. We have about 4 people working in our events area, the conferences that we run you know about. We've got about 2.5 FTE in the communications area. We now have 3 policy officers. We're really pleased to have complement back up to 3. We were down to 2 for a while. And then we have support, finance and admin folk to help keep things on the road. So it's a pretty modest agency, and trying to tackle all of the things that people want to make a public health issue is an ongoing challenge. And literally the email flies and the phone rings every day for people who want to make something a public health issue and for us to join them in their advocacy. So it's an ongoing issue, and it's part of our challenge is to prioritise, and that's very much what this challenge was for the upcoming federal election. But let's get started and get stuck into some of the detail. And the first thing that we've listed here, and it's not in order of priority or importance, it's important for me to be clear on that front. There's 7 asks, all are of equal importance. The first one is one that we've been thumping the drum on for probably more than 30 years, the establishment of the Australian Centre for Disease Control. This is a commitment that came out of the Albanese government. Actually, it was the Albanese opposition made this commitment prior to the 2022 federal election. And it's important that you pay attention to these 3 points, because they committed prior to that election that they would improve pandemic preparedness and response by establishing Australian Centre for the CDC. The Australian CDC, the CDC will ensure ongoing pandemic preparedness, lead the federal response to future infectious disease outbreaks, and work to prevent non-communicable or chronic disease as well as communicable or infectious diseases. That last point is one that has absolutely faded into the background. We continually remind the government of the importance of that, but essentially the argument we're getting is that you've got to start somewhere, and the immediate focus relates to dealing with infectious disease outbreaks, given that it came off the back of the 1 in 100-year pandemic. PHA has been making this case for some time. Former President Taryn Weeramanthri and I drafted a editorial that was published in our journal, Australian New Zealand Journal of Public Health, back in 2021, and the issues raised there remain relevant, and for those who want to follow that up. But it identifies that the debate has raged since 1987, when Bob Douglas, who was epidemiologist and founding director of NCEF at ANU, raised that question. So it's been an ongoing issue since then. More recently, our friends at the Grattan Institute and Peter Bearden came up with a very nice Highway to Health, wrote a report on the CDC focusing on what it might do and what it might focus upon and what its importance is. More recently, the COVID response inquiry out of the pandemic, this is called by the Prime Minister, run by Robin Crook, along with Catherine Bennett and Angela Jackson, ran this almost year-long inquiry into Australia's response to the pandemic. And one of their recommendations was to finalise the establishment of the Centre for Disease Control and give priority to essentially systemic preparedness for future pandemics. Now, I'm just going to say now, there's a lot of content in these slides, and I'm not going to go through all of them in the time that I've got, but I'm happy to make them available for anybody who wishes to see them, and you'll see many of them have references to links where I've taken the material. Most recently, the question is where we're up to. Most recently, there was an announcement in response to the COVID response inquiry by Mark Butler as Health Minister and Jim Chalmers as Treasurer, where the government made a commitment of $251.7 million over 4 years to establish the independent body. Their target is to do so on the 1st of January 2026, and the interim CDC has been running within the Department of Health and Aged Care, and there is separately an entity which is the CDC Establishment Branch operating within the government to put the machinery in place. But as we're going into a federal election, there's no certainty Labor will be in government, and so we are in the process of trying to determine what the opposition's attitude is towards the establishment of a CDC. Last week we put out a media release and got pretty reasonable coverage, and we did so jointly with our friends at the Australian Society for Infectious Diseases. We also had Professor Alan Chen, who's recently been made an AC, kind of an Australian version of a knight in the Australia Day Honours Awards, as spokespeople on that media release as well, and we got pretty decent pick-up on that. And in every interview, I sought to ask the question about whether the opposition will or won't support the establishment of a CDC. So far, we don't have a definitive statement on that. The only response in the media that I could find was opposition Shadow Health Minister Senator Anne Ruston said that the government was not serious about implementing the reform, despite Labor promising to set up a US-style Centre for Disease Control almost 5 years ago. We've seen very little detail about it since. She then went on to say the supporting legislation is not even being released for consultation, let alone brought to the floor of the Parliament. It is clear that we will not be finalised before the next election. Labor's snail pace implementation of this key election commitment shows they are not serious about establishing it. This represents another broken promise from the Albanese government. Unfortunately, within that statement, there's no indication as to the intention with regard to the opposition in the process of putting in place the Centre for Disease Control. So we're looking to hopefully get that clarified before people go to the polls in May. The second ask is about investment in prevention, and here I'm going to bounce through some basic financing with regard to health in Australia, and I use these slides frequently and I apologise for people who've seen them before, but essentially it's built on a premise that came out of the establishment of the National Preventive Health Strategy, which was established by the previous government in 2021, I think it was released when Greg Hunt was Health Minister, and I'll show you at the page where it was referred to, but within that was setting a target of 5% of health expenditure going into public and preventive health. That was a target set in the National Preventive Health Strategy. It previously been adopted by the West Australian government. They did a Sustainable Health Review in 2019, and that's where that figure came from, as a recommendation for the sustainability of the health system in Western Australia. So that 5% figure has been a bit of a mantra, and I just want to bounce through the current financing arrangements within Australia. Firstly, it's worth understanding what the baseline is. In Australia, based on the AOHW data report released late last year, we spent about $252 billion, or about $9,500 or $9,600 per person on health in 2022-23. That figure's been growing faster than inflation. The proportion of GDP has been growing, and it's gone from 8.7% in 2006-7 up to 9.9%. So as a proportion of national spending, health is getting bigger, and it accounts for about a quarter of tax revenue. Quickly recognising where those funds are coming from, about 40% from the Commonwealth, about 30% from the states, 15% comes out of individuals' pockets, health insurers, less than most people would expect, contributing about 7.7%, and other NGOs just over 6%. And how's it being spent? Well, you can see the big increase in expenditure in public hospitals. Primary care is a slightly downward trend, but you've heard recently the announcement of the federal government to intend to inject $8.5 billion into primary care. The opposition quickly neutralised that as a political issue by committing to that as well. We then went on to hear that it wasn't going to make any difference, which drove me nuts, and I wanted to say publicly, we'll give it to public health, we'll use $8.5 billion effectively, but I resisted the temptation to do that. So you can see the breakdown in terms of who's paying and where the money is going, and you can see further down that list you've got about 10% in referred or specialist medical services. Then there's another services category, a capital and a research figure, and the research figure around 3 or 4%. There isn't even a line there for public health. So it's too small. So we dig into the data and we find that there's a fairly consistent level below 2% of health expenditure going into public and preventive health. Very clearly, there was an enormous spike with regard to the COVID pandemic, and that took the figure up close to 7%. But after 2021-22, you can see that figure is very quickly returning back towards the previous level. We looked at how much was spent on the pandemic in the most recent data with a figure at around 3%, and that accounts to about 0.8 of 1% of that 3. And so there you remove that and we're back down to 2.3%. And I suspect it will, as time goes on, get much closer to that below 2% figure. And I mentioned the National Preventive Health Strategy, and you can see down the bottom there, and if I can use the pointer, you can see that 0.4 investment in prevention is increased, and it makes the point that not just the federal, but all governments, the target is to establish expenditure in prevention at about 5% by 2030. It's a target that not many have taken seriously. I'm hoping for an announcement today, which may come during this talk, which makes me a bit more optimistic on that front in one jurisdiction, but I can't release that until it's in the public domain. Moving on, ask number 3 is action on obesity, and we're looking for the next Australian government to commit to a suite of measures to tackle obesity within Australia. I'm not going to make the case here about the importance of obesity as it contributing to chronic disease. I'm sure all of you are familiar with the case that exists there. Most recently, the Burden of Disease study released late last year again showed that obesity had overtaken tobacco as being the greatest cause of burden of disease in Australia, according to the measures that the AOHW were reporting. So the range of measures, and we're talking about legislation for stronger control and marketing of health foods and beverages, improvements to food labelling, mandating health star rating, improved labelling for infant and toddler foods, ongoing public funding for health promotion campaigns, a sugar-sweetened beverage levy that will drive reformulation to reduce the energy and caloric intake of sugar-sweetened beverages, and a review of the food regulatory system in Food Standards Australia and New Zealand, or FSANZ, the act of which is up for grabs and in play at the moment. How do we know what to do? well, a whole conga line of reports have been published, and it's been an extraordinarily consistent set of recommendations going back to one that was produced under the National Preventive Health Agency, which was generated by the Rudd-Gillard government and dismantled when the Abbott government came in 2013. And it's worth noting that Peter Dutton was the health minister at the time the National Preventive Health Agency was dismantled. They did a number of reports about the healthiest country by 2020. We look over our shoulder and realise we didn't quite achieve those aspirations. The page I've got here is the alcohol-related one, but there was one on tobacco and obesity of equivalent nature and timing. We've got our friends at what was then called the Obesity Policy Coalition, now the Food for Health Alliance, and their Tipping the Scales campaign, which is about a consensus statement for the prevention of obesity. I mentioned the National Preventive Health Strategy. There's the National Obesity Strategy, and there's an extraordinary level of consistency in the recommendation of these reports. And then more recently, the Obesity Collective, came out with a set of recommendations in March 2024. And after that, in June 2024, the House of Reps Standing Committee on Health, Aged Care and Sport released a report led by Dr. Mike Freelander, a paediatrician, now member for Macarthur, who led this committee and got almost complete sign-off for this report in the state of diabetes in Australia. And again, a lot of those recommendations align with the other reports that I've nominated there, and they align with the kind of recommendations we'd like to see with regard to tackling obesity within Australia. Because Kate's there, I will say it, because otherwise she'll beat me up afterwards. This is important to look through two lenses. One is to address the existing obesity, overweight problem within Australia, and that is to give appropriate support and treatment for those who already are already overweight or obese, as well as looking through a preventive lens. And I don't think it should be either or, it needs to be both. And that kind of recommendation is consistent in the kind of reports that I've been talking about. And we very much support action on that front. So we'll be looking for whoever forms government next in Australia to come forward with a raft of measures. And just as a quick note, this is not unheard of or impossible. We know, for example, that this government made an enormous commitment in terms of a range of responses to tobacco and vaping. And it wasn't just one measure, it was a raft of things. There were tax measures, there were programmatic measures, there were policy and regulatory measures, there was law enforcement measures and the like. So very rarely is there a single magic wand to any public health challenge. Obesity is probably at least an order of magnitude more complex than tobacco or vaping. But there are signs of governments having capacity to walk and chew gum at the same time by putting in place a raft of effective measures to tackle this challenge. And I'd be remiss if I didn't mention Peter McClure's email to me this morning. He said, don't forget to talk about physical activity. And absolutely, physical activity is a necessary and important part of the response with regard to not only obesity, but as a standalone issue. Physical activity is a vitally important public health challenge that I think we've underdone. The simple reality is, if you could put the benefits of physical activity in a pill, it would be prescribed for every single person on the planet. There is extraordinary diversity and range of benefits of physical activity for the entire human population, and we should never forget that, and it should never only be looked at through the prism of obesity. Hopefully Peter won't beat me up now that I've done that. Okay, moving on in terms of our asks, very important, and this is a core principal issue for PHAA, and that is investment in First Nations people's health. We very much stand alongside the Aboriginal community-controlled health organisations with regard to this. The extent to which that Aboriginal controlled or Indigenous controlled effort to respond to the gap that exists between Indigenous and non-Indigenous people in Australia is a fundamental principle to tackle that challenge. We support things like the Tackling Indigenous Smoking program, and Rebecca mentioned the wonderful Emily Banks, and Emily's been very much a champion of work on tobacco control for Indigenous people, and Tackling Indigenous Smoking program is a really important one we've supported in an ongoing way, and they are well resourced to tackle that challenge, and they're making progress, but there's still a lot more work to be done. But of course, the work done by the commission by Nacho done by Equity Economics in 2022 estimates the gap in health expenditure between Aboriginal and Torres Strait Islander health is $4.4 billion per year, of which $2.6 billion is Commonwealth share. This equates to just over 5,000 per Aboriginal and Torres Strait Islander persons. So there is still work to be done. This is data from the Productivity Commission. This is their 2024 report looking at some of the measures that they capture within that Closing the Gap program. And you can see that there's measures there in relation to health and wellbeing development, but it also recognises the more societal and holistic approach that is very much the hallmark of Australia's First People. And it's about families and kins and some of the measures there, education and training, housing justice, and issues around country, employment, language, digital inclusion and the like. And you can see that those measures are being monitored. It's worth noting that later this week we expect to close the gap. That is the non-government and Aboriginal-led process of looking at this challenge. Their report's due to be released on Thursday. They've been good enough to give us a pre-release version of that, but I'm not going to breach their embargo. I'll just encourage you to keep an eye out for the National Close the Gap Day report and the 2025 report launch, which is happening on Thursday. Ask 5 relates to climate and health, and of course we can't go through even a 3-month period in Australia without seeing some kind of climate challenge, disaster of some kind or another. And of course there's probably people on this call who've lived through the recent tropical cyclone in southern Queensland and northern New South Wales. But it comes down to the fundamental challenges we have with regard to tackling the climate, but also recognising very specific health considerations relating to climate change. And the fact that the interim CDC has now established a climate and health unit, and they've released a national health and climate strategy, and you can see the objectives they've articulated there. One important and starting one is looking at our own backyard. Health system resilience and recognising the fact that the health system in Australia contributes in terms of greenhouse gases about the equivalent to that contributed by the state of South Australia, roughly 8%. And so one of the fundamental challenges is health system decarbonisation and looking inwardly to those things which the health sector can control. Also issues around an international collaboration, health and all policies and so on. And that interim CDC has also established a national health and climate strategy implementation plan. And like all such big movements in public health, they do need persistence, consistence and resources to proceed. And so there's a whole lot more work to be done in that area, and we're keen to get an indication from whoever wants to form government as to their attitude to tackling that fundamentally important, effectively existential challenge that we face. The next one is one that I get really cranky about. So get ready for a rant. Here it comes. Gambling addiction, and I'm not even sure we should use that turn of phrase, because for me, and I was talking to someone who's doing a consultation about this in Western Australia last week, that depicts the gambling challenge in part as being about a small group of aberrant individuals who are doing the wrong thing. And that's, I think, the reverse of the way we need to think and talk about gambling in this country. Australians are by far and away the biggest losers in the world when it comes to gambling. Our national policy settings are the worst in the world, and that shows up in the amount of money we lose. And I'm going to bounce through some numbers for you, and these always blow me away. This is the data from 1998 up to 2023, and you can see that extraordinary increase in growth in what's called turnover. That is the amount of money that Australians bet. They wager, they put on, whether it's in the neck of a poker machine, online gambling, whatever it may be. Now, it's worth noting the scale. This is value in millions. And what this number is $244 billion each year. So we bet almost as much as we spend on health in total in this country. Just take a deep breath and think about that number. I still find it breathtakingly infuriating. Anyway, I'll move on. Okay, so that's how much we put on the table, whether it's in a casino, whether it's at a TAB, whether it's bet accounts on our phones or whatever else. How much do we actually lose? This is reported in the form of what's called expenditure, and that is the amount lost in gambling. And that amount is at just over $30 billion, 31.4 from memory billion dollars. So if you do the calculation for that on a per capita basis, every person in Australia on average is spending about $1,500 on gambling, 1,527 from memory. Imagine the benefit that could be if that went into the pockets of every person in Australia. Now take a deep breath and say, okay, well, let's just make an assumption, a rough guess, and say half of Australians don't bet. People under the age of, say, 16, although we do know that teenagers are being enticed into online gambling. But let's assume people under the age of 16 and roughly a third of the adult population never bet at all. So that's about half the population are actually losing this money. So that means for those who are gambling, they're on average losing about $3,000 a year. That's a preposterous amount of money, much of which is going on offshore. And I won't go into the breakdown of pokies versus online gambling, but it's very clear. And you see particularly the gradient of that line that goes post-pandemic. So we had 2019 pandemic hits and losses for people couldn't get into clubs and pubs for poker machines and the like, but then the extraordinary bounce back since then. The gradient of that line is breathtaking. And now being at $31.4 billion, this is a national disgrace. Okay, and what's driving this? In part, governments have been bought. We're just seeing $9 billion going to government revenue, and that's combined all federal, state and territories government revenue. And you can see that line creeping up from just over $2 billion in 1998, now up to $9 billion. And again, the gradient of that curve since the pandemic struck. Okay, so what do we need to do about that? Well, the answer is there's been a parliamentary report, a House of Reps committee led by a member who is now sadly no longer with us. Peter Murphy sadly died of breast cancer last year from memory, and worked extraordinarily hard on this. Peter spoke at one of a PHAA event we ran on gambling in 2023 in Adelaide, and I spoke to Peter as she came into the House on for sitting weeks towards the end of her time, sadly. An absolute hero when it came to tackling this issue. And it is a genuine disgrace that government has not implemented the recommendations of this report. From memory, there was 31 recommendations, might have been 23. Sorry if I got that wrong. And essentially one of the key recommendations, not the only one, is to have far greater controls on the way in which gambling is promoted. And we all know the ubiquity of promotion and marketing of gambling in Australia, and it just simply has to stop. No one is suggesting we ban gambling. All we're doing is recommending a proper set of controls on the way it's been managed, promoted, marketed, and the governance around it. And bearing in mind, of course, the enormous growth of online gambling, much of which is money going offshore, going out of Australia's hands. It is just a disgrace. And I summarise this in a simple way, and that is Australia's policy on gambling and our blind spot there is equivalent to the blind spot the Americans have when it comes to gun control. That's how out of step Australia is with regard to control of gambling compared to the rest of the world. Final one, universal oral health care. And we're suggesting a long-term approach to this. This has been an issue for PHAA for some time. Older members will remember a Bite Back campaign probably more than 20 years ago, looking to get oral health care in a Medicare style system. We recognise this is potentially a very expensive proposition and one that not many governments are prepared to tackle. So we've broken it down into a bit more detail with regard to how it might be done, and it can be started with the most vulnerable Australians. There are programs around to support oral health, which are being underutilised. We think those should be more actively promoted, but there is a need to expand further the extent to which we invest in the fundamental of oral health care. So that's the outline of our 7, and remind you of each of them. It's investment in prevention, it's action on obesity, it's the establishment of the Australian Centre for Disease Control, focus on Indigenous health, climate and health, gambling reform, and universal oral health care. We've got a web page, and it's Vote for Public Health, and I think Rachel's put that in the chat. so you can have a look at that yourself. We've got a one-page, very simple summary, which I've been toting around Parliament House for more than a month. Everybody who stops or even slows down their walking pace gets one shoved in their hands. And we've also got a more detailed 14-page document, which you can find under the resources tab of that vote for public health. And that goes into more detail on each of the 7 asks that we've put in place. We've got social media tiles to help promote that, and we encourage you all to make use of that and promote it through your own networks. Now, I was asked, and now I've got a couple of minutes to also cover our policy review cycle, because that's part of the mechanism by which PHAA engages with our expert members in public health and gives people an opportunity to have an influence on the policies that we have in place. We've got over 100 policies on a whole range of public health issues, and they're publicly available, and they get downloaded an extraordinarily large number of times. It's probably in excess of 1 million a year last time we counted. They get used for student assignments, they get used by politicians and people in government and so on, and on various topics. When you just Google a public health issue, in some cases our policies are first thing that comes up. So it's on a whole range of issues, and they're largely driven by our special interest groups, or SIGs. And we have a cycle by which we review them all every 2 years. And so every 2 or 3 years. And so roughly 1/3 of all of our policies are reviewed every year. The process starts in February, and it gets finally signed off at our annual general meeting in September. So you can see the key dates for that, where we can communicate with our membership, and we have the policy team, and Lily Pratt has been leading that last year and this, and doing a great job, where we invite people to either put forward new policies or review the ones we've currently got, and we go through a detailed process of fact-checking and ensuring that they're high-quality evidence-based public policies, because essentially the PHAA is an organisation made up of members who pay money for the privilege of doing more work for free that benefits other people. So we draw upon the expertise of our members to generate policy which we hope will be adopted by government, state, federal, local, if necessary, to improve the health of the populations they're meant to serve. So I'm happy to take questions, but before I do, I'm going to quickly do an ad. And the ad is, I want to talk about the organisation I've had the privilege of being CEO for now almost 7 years. We're a not-for-profit. We are a registered charity. We have 3 main sources of funding, and this is a transparency issue for me, and I say this to every politician, every policymaker, every journalist I speak to. We have 3 main sources of funding, and it's important that we're transparent where our money comes from. One is through our membership, about $300,000 to $350,000 a year. We have about 2,000 members. We have individuals and organisational membership. 2 is through a grant from the Commonwealth Department of Health through the Health Peaks and Advisory Body program, and that's about $600,000 a year. The rest of our funding comes through the running of events, conferences and events that we run. We run about 5 conferences, usually on a national basis, sometimes internationally. And each one of those events can make money, lose money, or break even. So we look for support in terms of sponsorship of those conferences, and of course, registration funds. So we're very transparent about where our money comes from. We ask all other organisations we deal with to be the same. And that's a strength that I believe we have, because it means we can be clear about what our motivation is. So why join this mob? If you're not a PHAA member, and you've already heard Rachel talking about her role in the New South Wales branch, Kate is our New South Wales branch president. This is an opportunity for people to genuinely engage in the policy process. There's an opportunity for early career and student members to gain connections, gain experience, and so on. People who've won scholarships, they get opportunities to attend our conference and get funded to do so, a range of those kind of benefits. We have mentor programs and the like. And we have a student and young professionals in public health committee. I suspect that email may or may not be out of date, not sure. And there's a vision for the way in which the SIF operates its part of the business. We have, I mentioned the special interest groups, and we have 18 special interest groups, and that's a list of some of them. I don't think that's quite all of them, but to give you an idea of the diversity of the special interest groups that we have. And membership, $60 a year for full-time students. Membership entitles you to very substantial discounts for registration for conferences. It also means you get a very substantial discount with regard to Okay. A very substantial discount with regard to publishing papers in our Australian New Zealand Journal of Public Health. Now, I've just got a message through which has popped up on my phone, which means I think I can probably now make this publicly known. And I believe that the West Australian government that's just been re-elected, the Cook government, has announced their ministry, and I believe that they're establishing a Minister for Preventive Health. I think that's just been announced, and the person who is occupying that is not the person I thought it was going to be, but that's okay. But the most important thing is that an Australian jurisdiction has established a ministerial position, which will be in Cabinet, which is the Minister for Preventive Health. And so we'll be leaning into that to give the greatest possible support to that minister, so as to ensure that they can be successful in prosecuting the target that West Australia has set, and that is getting to 5% of health expenditure going into prevention by 2029. That's the rant. There's a discount if you join this week up until midnight on Friday. We'll waive the joining fee, which is normally $45, and I want you to join our mob. So there's a rant and a half. I can see Rachel's laughing at me. That's okay. I'm used to that. Happy to take questions.
Thank you very much, Terry. I think for many of us who follow the PHA, and I've been a member for a long time, every time I hear you speak, I learn something new about the organisation. I think I have this imagination that you're off in Canberra doing your thing, and it's really good to hear you explain just some of the day-to-day operations of the PHAA. I think I won't be alone in having learned something new from listening to you speak just now. We've got a range of questions popping up on the chat and the Q&A. I will just kick off. Well, there's a few related to obesity, so I'll call those ones up in a minute. But Emily has asked a question about how public health expenditure is defined. If you could outline for us a little bit how we get these statistics about how much is
well
spent.
done, Emily. And the reason I say that is because I was getting way too many slides. That was one of the slides I cut out of the presentation. Emily, it always comes up when we raise this issue of 5%, and I can tell you that there is a very clearly agreed definition. The Australian Institute of Health and Welfare used to publish annually the amount of money spent on public and preventive health. The most recent one was published in 2011. It related to 2008 and 9 financial year. And there's an internationally agreed definition. If you go back that far, you'll probably see, well, maybe that's a little bit out of date. We need to update it. But it includes the things that you would expect that it includes. Everything from immunisation, communicable disease management, screening programs, traditional health promotion activities, food regulation, and the like. So it's a raft of measures that are pretty core to what public health is, and pretty much generally what only public health does. So you can start messing around with the definitions, but it's broadly pretty well agreed. Andrew Wilson tells me that when that 2011 report came out, people were grumbling because of definitional issues. And rather than sorting out the definition, the AOSW threw their hands in the air and stopped publishing the report. So we've been working since then to try and get it reinstated so we do get an annual scorecard. But it always comes up, the definitional question, and I don't think it's a problem that's unsolvable.
I'll call on Kelly if you want to unmute or put your video on and ask your question, Kelly. I think this is in relation to one of your slides, Terry, when you were speaking about the ask on obesity prevention. Kelly, are you online? If Kelly's not available, I'll read the question, and then I'll call on Elise and Rona, who have a similar thematic, I think. Kelly's asking, are those figures for spending on public health just in the government sector? And does it include government grants that might fund not-for-profit organisations?
It does include government grants that fund not-for-profit organisations that does public health work.
Okay, I hope that clarifies. It was a slide that was early on in your talk.
Yep.
Okay, Elise, do you want to ask your question?
Sure, I'm hoping this
is working. And then I'll call on Rona, so get ready.
If it's okay, I was going to be sneaking a second one. My first question was around with Ask 3 and the advocacy actions. How does size-inclusive health promotion research kind of integrate or get applied in that concept? Because the language of the ask, I can appreciate, is meant to be a bit snappy and grabby and work for people quite quickly, but it is contraindicative of size-inclusive health promotion.
When it comes to the language, yes, this is written not for a public health audience. our advocacy documents aren't written for our own people, and so we do set aside some of the precision of language which is, I guess, expected when speaking amongst ourselves. So the challenge for us, and part of my job, is speaking public health in language that a 7-year-old can understand. And that's not being disrespectful to anybody. It's about an objective to be to achieve the greatest possible clarity. Now, you and I, and I'm delighted to talk about the detail of how we express some of these things and how the trends change in public health. And I've been doing it for more than 40 years and have followed and been involved in many of those arguments about language and semantics. But the older I get, the more determined I am to be as blunt, clear, and explicit as possible. So I'm very unapologetic about not being caught in some of those kind of semantic arguments. So that might sound a bit pushy or forward or aggressive, but I'm increasingly convinced that we do need to speak in a language that the people who are listening and the people we need to influence can clearly understand.
Great. I think that's probably as far as the conversation go here, but it's really, I really am excited to see all those action points. The part question that I've got that integrates with that is the fact that I'm actually on the special interest group for mental health, and we're reviewing the policies at the moment, and the one we're reviewing is mental health and physical activity and mental health and well-being. And
Right.
It obviously integrates with Ask 3, because being able to have access to physical activity means that you can actually kind of contribute to your health and well-being, and so I guess what's the position in regards to how you want to integrate some of the policies that are being reviewed now into the advocacy work?
Yeah, and that's a great question. It's a really important one, and we go into some of that kind of detail about how we can join those things up through our conferences as well. We've got a mental health promotion and prevention conference being scheduled for March of 2026. I was going to say 6 or 7. I lose track a little bit. We're doing it every second year. Actually, just only minutes before the webinar, I got an email from our partners in that Prevention United, who are helping to lead the charge on mental health promotion conference that we're running there. And essentially, your key question is about connecting up our policies, and that's one of the challenges we have to join up our special interest groups. And so there's one argument that says you're siloed if you have child and adolescent health versus health promotion versus injury prevention, because of course all of those things connect up. But what we try and do is make sure that we do that as much as possible, and we always encourage SIGs, particularly when they're on dealing with an issue where it's cross SIG, and Aboriginal and Torres Strait Islander one's another one that could be across all of the policies that we do, and try and join those dots as much as possible. And I'll say 2 more things about that, and it's the nature of one of the challenges that we have. The first is to say, I think physical activity is probably underdone in PHAA, and I've kind of thought that for a little while, and I'm still wrestling with a way in which to deal with that. Do we establish a physical activity SIG? Do we find other ways of doing it? We try and highlight it in our conferences. But separate from that is the question about how we organise ourselves. And I use the line that our members pay us money for the privilege of doing more work for free that benefits other people, and then I don't add in their own time. All of our members have families and lives and careers and, all of those responsibilities, and have to get some downtime. So one of the things I'm always cautious of is not overburdening people to give an expectation of achieving perfection. So we create an opportunity for people to make those contributions to the extent to which it's possible that they can. I try and avoid creating unrealistic expectations. And the other thing I say on a very regular basis is our members should always feel good about the things that they do, not feel guilty about the things they don't do under the banner of PHAA. And having occupied any number of various roles in PHAA, I've kind of gone through that experience myself. So
I'll keep that in mind. Yep, I'll keep that in mind as we take it forward. Thank you.
Please do.
And also, just before we go too far away from the theme of physical activity, I think Rona, I think Joy, probably your question's been spoken to already, but Rona might want to add your point that's come through on the Q&A. If you want to unmute, Rona, are you available?
Yes, thank you, Rachel, and thank you, Terry, for a very informative and interesting session. It's more a point than a question, and I appreciate what you've spoken about physical activity. But I wonder if, given that PHAA has supported the Asia Pacific call to action to support more Australia's to move more, that is also aligned to the upcoming federal election. It seems a bit of a missed opportunity not to better align that within the obesity ask and the prevention ask. I was wondering if you have any comment on that. I was also thinking myself that maybe that's something I need to consider doing within a SIG when you mentioned the physical activity SIG. So appreciate any further comments, but thank you very much for today.
You're very welcome. And when it comes to your question about physical activity, listen, some of my very, very good friends have been physical activity advocates for years. Fiona Ball speaking at our conference in late April here in Canberra, albeit that she's and the theme is prevention is political, and she can't come because of the politics of the US pulling their funding from the WHO. Fiona's been leading physical activity at the World Health Organization for some years. Fiona did a PhD in physical activity at UWA back when I was in Perth. Physical activity is a very complex, multi-sectoral issue. Not only is it about the promotion of physical activity, it's about infrastructure, public transport, cycleways, access to pools, etc., outdoor space, and it's very much a cross-government challenge. So in the same way that I think obesity as a broad issue is kind of an order of magnitude more complex perhaps than tobacco, albeit that let's not downplay the complexities within the tobacco field. Physical activity similarly is that order of magnitude more complex. And I'd be delighted to try and find and land on a clear and explicit message with regard to physical activity, because it's one that, in my experience, is too easy for any policymaker to say that's somebody else's problem. Whether it's urban planning, whether it's transport, whether it's health, and you could keep on going. I'm really interested to see someone work on and come up with sellable messages that we can put forward measurable and tangible outcomes with regard to physical activity. And there's a whole bunch of challenges, physical activities, kids in schools, policies that vary from jurisdiction to jurisdiction, different stages of school, etc., etc.
Anita's had to drop off the line, but she's asked a question in the chat that I think probably other people would like to hear read. She says, we talk about the harms regarding gambling, but are we, public health folk, doing a good enough job calling out that gambling isn't the norm? It's an Australian anomaly.
Well, my answer to that, and I'm happy to talk to Anita later, is by way of illustration, and I talk about resource and capacity all the time because, that's the big debate, whether it's health, housing, anything else within the kind of public sector. When it comes to a focus on tackling gambling problems within Australia, I'm talking from a kind of more societal and public health point of view, there is one agency that focuses on that in this country, the Alliance for Gambling Reform. There are some very active and very diligent and very successful researchers in the field. But the agency, the Alliance for Gambling Reform, has, I think it's 3 or 4 staff. You'll have known it from the name that Tim Costello is kind of lead advocate. But these folks got 2 bob and a bit of string. Seriously, they are ridiculously under-resourced for the size of the machinery and the industry that they're tackling. And it's one of the reasons why I've probably thrown what some may consider a disproportionate amount of weight behind it. And the other thing is that people say, how is this public health? What's gambling got to do with public health? And I think it's a fundamentally tangible example of a social determinant of health. It's one that we can actually see genuine change on and change the preposterous and disproportionate policies that exist in Australia, particularly compared to what goes on elsewhere in the world. And it's corruption, pure and simple. It's the flow of money that has us in this position, the power exercised by the gambling industry, largely through their compadres in the professional sports world and the commercial media world, who are beneficiaries of that industry, And I'll finish the figures. We spend $244 billion. We lose $31.5 billion. We pay $9 billion in tax. And yet we won't change the policy because of the influence of their spending in commercial advertising, the broadcast medium through which politicians get their message out. And what's spent there is something like $300 million a year, 0.1% of the amount that people lose. It can be bought out. We can find a means, we've done it in tobacco, of a modest levy. Some people don't like the idea, but I think it's a practical and tangible solution to the money problem, of effectively buying out the extent to which the Australian commercial media sector and professional sports rely upon gambling as a revenue source. It's a very simple economic solution to a fundamental societal problem. And I think we need to do more about it. And that's why I weigh into it the extent to which I do. And, people might think I do too much for it, but I tell you, it just drives me nuts.
Rebecca, you've got a question in the chat. Do you want to read that?
I will. Now I can unmute myself. Thanks, Terry. That was great. We've had a national injury prevention strategy under development for quite a few years, and the federal government seems to be sipping on it. And I mean, I know it's being shopped around to all the states and coming back, but doesn't seem to be a great deal of enthusiasm to actually get it released. So I guess a question about what other and I think it's probably unlikely that we'll see that before the election. It's probably a pretty low priority. So I guess, I guess that's a question of how do we actually push things like that forward. And again, it's always pretty, in my mind, unless you've actually got a funded action plan, we've had injury prevention strategies for years, but we've never actually had funded action plans. So, that's, again, says something about priorities. So a question about that. But the second, I did want to also say, we need to also really consider, we're very good at actually working with Labor governments. How do we actually work with you? How do you work with the opposition? That's really critical. We need to make sure that preventative health isn't politicised. It's actually something that's just business as usual and just really, talking to the community about that. How do you work with both sides of government?
Yeah, Rebecca, I'll take both of those on and mash them together in terms of my answer. The first point, the National Injury Prevention Strategy, is something I've been asking about every 3 months. I know where it sits in the department and who it sits with, and I know why it's kind of sitting in the background at the moment. You and I can talk about that separately if you like. I think you're right, it won't be released before the federal election. But I go back to my point about investment in prevention, and one of the points that I make in an economic sense is that some of the best buys in public health, in my view, that provide short-term benefit is injury prevention. And we take, for example, the evidence-based programs on falls prevention in the elderly. I've seen evidence that crystal clear that the investment in programs of that kind return investments within 3 to 5 years at a very substantial rate. So if fewer of our older Australians are turning up at emergency wards with fractures, that's an immediate and substantial saving to the health system. So I think there's a really powerful and clear economic argument to make with regard to injury prevention. And that's an argument that has no political flavour to it. That's a pure investment question. And one of the arguments I've been making with regard to investment in prevention, one of the challenges is the return in many cases is off into the future, and governments are not always enthusiastic to spend money today to save money in 3, 5, 10, 15, 20 years' time. But this is one where I think there's a pretty short-term return on investment, and I'd like to think that National Injury Prevention Strategy highlights that. And I know there's some work being done by a couple of groups that's focusing on the economic benefit of injury prevention. And then circling back to your question about working with the opposition, I do communicate with the opposition health spokesperson's office. I know the people there and they're happy to take my calls, and while occasionally we don't have necessarily the same view on various public health issues, we do have a functional relationship. And I also point out that our top 10 successes in public health, which we published in 2018 in the lead up to the 2019 federal election, we identified successes in public health and attributed them to the Minister of the day. And there's a substantial proportion of those that gave credit to a number of coalition ministers at that time, and they're named in the report, and so we're able to point out very clearly, we give credit where credit's due. Greg Hunt was a very strong minister when it came to tobacco control and vaping. He didn't quite get through the things we would have liked through his cabinet, but undoubtedly he had absolutely his policy heart in the right place on that issue, and I'm very comfortable to say that in the public domain. And there's various other examples. So we absolutely have to be able to work with all sides of politics, includes the crossbench, the Greens, the Coalition, and Labor. And for what it's worth, and anybody can read this in the political punditry, I suspect that the next federal government will be in minority, not majority, and so the importance of the crossbench becomes paramount, and we've got good connections with the crossbench as well.
Right, Terry, we thank you so much for coming and speaking with us today. I can say that on behalf of everyone on the line. Much work to be done, but I think with you guys in Canberra, we'll be ready. If people want the recording, you will soon receive an email with the information for that. And I think the Public Health Association will have this recording online, slides and so on. Yeah, please get in touch with me. My email is in the chat. And we look forward to seeing you next time.
Good on you. Thanks, Rachel. Thanks for organising it, and Rebecca and your team for making it happen. Kate for your contribution, and anybody, I encourage you to go onto the Vote for Public Health website and promote the hell out of it through whatever channels you've got available to you. The election is going to be a really important one. Thank you, folks.
Thanks, Terry. Thank you very much.
Cheers.